Good morning, everyone, and welcome back to another ACC House Call Special Edition video conference interview as part of our ACC 2020 virtual coverage. I'm Kevin Kunzman, Managing Editor of HCP Live. We're on day 2 now of ACC, and the highlight of today, I'd have to say personally, is a lot of new TAVR, a lot of new surgical outcomes and related therapies discussions, sort of highlighting the Sunday mornings, late breakers and overall sessions and discussion points that we have here for the meeting. So I'm actually joined now by Dr. Ashish Prasad, Associate Professor of Medicine at Banner University Medical Center, Cardiac Institute, and University College of Medicine at Phoenix. Dr. Prasad is an expert into the field of TAVR and invasive cardiology, and he's going to share some perspective on what he thinks about the new PARTNER 3 data, the 2-year outcomes that sort of highlighted again this morning's session. So, Dr. Prasad, you want to take a second to say hi to everyone?
Yeah, hey, good morning, everybody. It's a pleasure to be with you, Kevin, and share some of this data and my insight into what I think will be the clinical implication of the 2-year PARTNER 3 data.
Yeah, absolutely, and excited to have you and get a little more perspective on it. We've had a lot of TAVR discussion leading up to and including in this weekend, and it seems like it's sort of culminating in this moment where we're now talking about its use in low-risk patients and what it looks like 2 years out now. And with it came the discussion point that we're going to try to extend this to a decade to ensure that this is continuously safe and effective and just a preferable method for both clinicians and patients. So maybe we could start there. I think the highlighting number was 37% reduction in death, stroke, or rehospitalization for the low-risk patients over 2 years. What stood out to you, Doc, as some of the most important information to come out of PARTNER 3?
Yeah, I mean, I think the most important piece of information was that at 2 years out, the device is still non-inferior and probably superior in terms of rehospitalization data compared to surgical aortic valve replacement. However, it needs to be kept in perspective that this data set includes a selected group of patients at low risk for transcatheter aortic valve replacement or surgery. In other words, patients with tricuspid valve disease and not bicuspid disease, patients with 65 years or older, and patients who did not have underlying aortic root pathology or mitral valve disease or complex coronary disease, all of whom were excluded from this data set. So I think it really, in my opinion, points to what I would call precision medicine being applied based on information that the heart team has at the local institution, which will decide what the best therapy is for patients with low risk and aortic stenosis. There would still be a vast majority of patients who would benefit from transcatheter aortic valve therapies, but then there are some groups of patients in whom we need to look at not just the now and the in the moment decision, but evaluate it for the patient's life expectancy or projected life expectancy. In other words, if this was to be a 62-year-old patient, what we need to think about is for a 20-year lifespan or a 25-year lifespan of this patient, he's clearly going to need more than one therapy, with the durability of the therapy of somewhere between 10 to 12 years is kind of what we're looking at for both surgical and aortic valves. Then what would be the correct strategy to adopt? In other words, should we do the TAVR first and then 10 years later think about doing surgical aortic valve, or instead do a surgical aortic valve first and then plan on doing a TAVR valve? Or with now newer disruptive technology potentially out there for increasing the durability of surgical valves, maybe do the surgical valve and then see how the patient does. And if the surgical valve lasts 20 years, then we've basically don't need to do any more advanced therapies or valve-in-valve operations in this patient. So personalized medicine decision-making that's individualized to the patient's projected life expectancy are my take-home messages, because there are certain signals coming out of the study that point to certain events that occur at increasing frequency with TAVR. And we can talk about those in the next few minutes about why I think that may be the way to go.
Yeah, would you want to just expand on that now?
Yeah, so the two things that jumped out was the fact that there were more incidences of what we call VARC2 defined increasing gradients and higher pressure differentials, suggesting that there may be valve thrombosis that occurs with more frequency with TAVR than it does with surgery. And if that is true at 2 years, and we don't know the temporal trajectory of this moving forward, it leads to some speculation that this may be a harbinger of structural deterioration of the TAVR valve occurring at a slightly more faster rate than what we thought was going to happen. We did not have any good, robust data for surgical aortic valve deterioration because it has never been looked at. And this trial and the 10-year follow-up in this trial allows us that glimpse in a very robust way, comparing surgical data compared to TAVR data prospectively over 10 years. So we'll really know when we follow these patients out into year 7, 8, 9, and 10, if there truly is a difference in the durability between the two valves. So that is the first question that came about. The second question that came about was the higher incidence of stroke in year 2, between year 1 and 2 with the TAVR group, and whether that's a function of this or whether that's a function of other episodic events such as atrial fibrillation or other events will need to be defined. The events were so low that you would need longer term data to see if there's a correlation between this event and strokes. And the last thing is, of course, the data related to paravalvular leak. I mean, we know that with surgical aortic valve replacement, there's less valvular leak than with TAVR. And what the long-term consequences of that are unknown and still an area that will need to be investigated. We do know that compared to the earlier transcatheter valves, the SAPIEN 3 performs fabulously because of the skirt and the incidence of moderate and severe paravalvular leak is almost none. But what the consequence of mild paravalvular leak is still remains to be defined.
That's excellent. And to follow up on the first point you're making, it seems like, it's a twofold benefit of extending our research, expanding as far as we can to further understand not only, the TAVR's capability and efficacy over decades of time, but also its competitors. It seems like we're working toward a point where this is going to be a much more particularized and personalized, as you used, like tailored medicine approach, in the next decade than it would be right now. So whereas it may be a preferred measurement, preferred practice by the patient, it's going to be a very specific tool for the clinician.
I think patients make informed decisions, but their information is a layman's perspective. It's, I think, the onus on the heart team and the physicians, both the cardiologists and the surgeons and the treating cardiologist, to present the data in an objective fashion so that the decision made by the patient can then be evaluated in a more objective way. Because obviously, every patient would want to not have their chest cracked if possible. But I think the onus lies on us to be able to guide that patient to the right therapy, because sometimes surgery is the right answer. And talking that patient through that initial increased invasiveness for the reasons that you might understand better than him or her is vital. And that's what I think comes out of this.